So this is a case of a female who presented with a relatively acute onset of right eye vision loss over a period of a couple of weeks, but worsening over a period of a couple of days. So on presentation to NYU Langone, she underwent a new MRI, which demonstrated a spheno-orbital meningioma measuring approximately 2.5 centimeters that was involving both the orbital apex and causing compression of the optic nerve, as well as invading into the middle cranial fossa and abutting the anterior part of the right temporal lobe. Given the degree of vision loss, as well as the acuity of the vision loss, we discussed a more urgent surgery for her in order to address this tumor and decompress the optic nerve as well as resect the tumor. On looking at her CT scan, she had a very pneumatized skull base, and by that I mean that her frontal sinus and her ethmoid sinuses went up and over her orbit and actually rode along her orbital roof all the way back to the area where almost where the optic nerve enters into the skull. That set of specific anatomic circumstances, as well as the location of the tumor, we looked for potentially less invasive routes and a more direct route to the tumor that would avoid the sinuses. So for that, we were leaning towards a transorbital approach, and specifically a transorbital endoscopic approach to access both the intracranial component as well as the intraorbital. I partnered with an oculoplastic surgeon, Dr. Stella Chung, who I work with on these TONES cases for minimal access orbital approaches. The TONES approach is a minimally invasive approach to the orbit that then gives you access to also portions of the intracranial space. Combining the MRI with the CT angiogram and putting those together and then creating our 3D model to go through and look at what does our window look like with each approach and which one will give us access to the entirety of the tumor, or at least the most important and impactful parts of the tumor. We put all that together and use that as our baseline for planning the approach. And then intraoperatively, we use navigation, where we take that model and we then in real time map out what we're seeing on the patient versus what we see on the imaging to confirm that we're going exactly where we're supposed to, that we're seeing the borders and the edges of where the tumor starts and begins, as well as the important structures that are nearby that we don't want to injure. The patient was in the hospital for about 2 days afterwards, so she went home on post-op day 2 and recovered very well. The vision improved even on the first day after surgery, so once that pressure was off of the nerve, it gave it a chance to start to heal. My name is Donato Passione. I'm an associate professor of neurosurgery. I'm also the chief of service for the Department of Neurosurgery.